I'm delighted to welcome back Dr. Michael Cohen, working in Israel, been a GP. I've actually been trying to arrange this meeting for a couple of weeks now, Doctor, and you've been a bit evasive. What have you been up to?
Well, I haven't been, don't take it personally, first of all. It's just been a pretty busy time recently.
Sure. Has it been completely horrendous, or?
In some senses, it's been very intense. Not to say that everyone's so unwell, but just that there are a lot of people who are unwell.
Mm. So the background is you're working as a GP. You're in Tel Aviv.
Yeah.
And I've just had a quick look at the stats before we came on, and the cases in Israel are like straight up. And we assume that's nearly all Omicron.
It's been a very rapid rise. Yes.
Mm-hmm. And you're seeing that as a GP. You're getting a lot of people coming to see you or calling in that are concerned about their health.
Well, also we get all the results automatically. So everyone on my list, anyone who gets a positive result, I get the result on my screen every day in real time. So I can see exactly how many of my patients have got it.
Interesting. So there's two things there. First of all, you're getting patients that are diagnosed as positive. And presumably some of those patients, well, they'll all know they've been tested, obviously.
Yeah.
But what do you do in that case? Do you call them to inform them, or are they already informed?
Well, they've already been informed. The moment they get the result, they know automatically, and they go into isolation.
Right.
The doctors who are responsible for them are informed, and so there's other branches within the Ministry of Health and the say the NHS equivalent, the health funds over here, where someone's going to call them up and say, you know, what's going on and how you're doing and stuff like this. And considering a lot of these people are actually low risk patients, there's not a great urgency to do that as long as they're in isolation and they're being looked after or looking after themselves. Most of the patients who I know of with Omicron are not very sick. Or certainly no more sick than a flu. Many of them have just got it like a mild cold. And yeah, some of them do get more sick for sure, but they are followed up one way or the other. But the number of people who've had it recently has been so significant that I don't always manage to reach the people on that list for days. Right. So because I've also got other patients who don't have COVID or who have COVID plus something else, and there's only so much that you can do. So to some degree, you're relying on those people. If they are that sick, they've been instructed to, you know, to contact the doctor themselves rather than waiting for the doctor to contact them.
Mm-hmm. Yeah. So most of these patients are just self-managing at home. The majority, right? Yeah. What the patients that do come and see you, what clinical features are they complaining of? They come and say, "Doctor, I've got a bad." What is it that's bringing them to you?
Most of them, I would say, have a sore throat, a mild or sometimes quite a high fever, headache, just feeling sickly, low energy, muscle aches, myalgias. Some of them have a runny nose, and one of the most prominent features is having a lot of phlegm.
Interesting. Right. And does that take time to develop, or does that happen early in the condition?
It happens quite early in the condition, but it really, like, a lot of them describe it as just being overwhelming, the amount of phlegm they're having to deal with. Like, they've had a handful probably who feel like they're not choking, but it's hard. You have to constantly get this phlegm out, and some of them are having quite a tough time in terms of having quite a strong cough. And I've even had some people who I wondered, or let's just say as a part of the analysis of what's going on with them, I have to make sure they don't have whooping cough, because coughs that are so strong that their body is leaping off the bed, that to me is a sign of whooping cough. So some people I've actually done checks to make sure they haven't got that. I haven't had anyone yet come back with whooping cough.
So medically, I guess we'd describe this as an expectorating productive cough. Is that what you're seeing?
I wouldn't say it for everybody, but quite a few people have. Yeah.
And does the phlegm look, the mucus look sort of infected? Is it greenish? Is it yellowish?
Most of them tell me it's yellow. It often starts clear. They or some people will have this impression that any coloured sputum must mean a bacterial infection.
Mm-hmm.
Viral infections also produce yellow sputum. And honestly, I haven't really seen more than a couple of people who've actually had a pneumonia as well, so a lung infection.
So the vast majority of the infections you're seeing are these classic upper airway infections, that features that we do know about, that we've been talking about for some time. But it sounds like the one you're seeing as well is a more prevalent cough and more mucus production. So they feel like they're coughing this up from the chest, do they?
They feel like it's coming up from here mostly. Most of them don't feel like it's coming from the chest. They feel like it's coming from up here. And that's probably where it is coming from for most of them.
So this is consistent with the idea of the Omicron SARS coronavirus 2 infecting the mucosa, primarily in the upper airways, causing inflammatory changes in those upper airways.
Correct.
Causing the production of the large amounts of relatively superficial sputum rather than the lower down clogging up, which might lead to the pneumonia. Is that consistent with the sort of pathology that we've been?
That's what it looks like. That's what it looks like. Yes.
Mm-hmm. So you've seen presumably a few hundred patients complaining of this, but only 2 with pneumonia.
I wouldn't say 2, probably about 5, honestly. I had one patient, this was the first time I've had a patient admitted into hospital since the pandemic began, actually, who's an elderly person. And
we know this patient was actually fairly elderly, wasn't he? But without giving the age away, he was
fairly elderly, but in and out of hospital very quickly. And doing okay.
Right. So from your practice of several thousand patients, you've had one hospital admission, and the hospital basically bounced them out pretty quickly.
Yeah. I mean, it's my practice has about 1,000 native Israeli patients. The number varies all the time. It's very hard for me to actually give you a specific figure because it's an open system of medicine here, which means that patients can come in and out of a practice. And in addition to that, I have a lot of other foreign patients, people who live in Israel for working purposes or visiting Israel. And that's actually a far greater number that come in a single year. So it's hard for me to give you a specific number. But if I was to say a couple of thousand, maybe 2,500, something like that. And I've only seen one person actually who's had to stay in hospital.
And I think it's reasonable to assume that most of those few thousand patients that you could potentially see are being exposed to Omicron over this pretty short period.
A lot of people are being exposed to it very, very clearly. I mean, it's spreading very quickly over here.
Mm-hmm. Now, have you been infected yourself as far as you know, given that you're exposed to it on a daily basis?
Not as far as I know. I'm taking a lot of precautions. Because I can't afford to be away from work, to be honest. So I'm being extremely careful, but I haven't had any symptoms. And so as far as I know, not.
I do want to talk about those precautions later in the videos because I suspect you might have some tips to keep me healthy, which I'd like to learn about. So do you feel that you can now essentially diagnose COVID from the clinical features, or are you still extensively using testing?
Well, I think especially at a time like this is not the time to be not using testing. I think we should be using testing as doctors. It may be how useful is it as patients? I mean, they're already starting to use less and less. I mean, that's the trend of where this is all going. At least in this Omicron variant. But I think for a diagnostic purpose, I think it's incumbent to use proper tests. Now, part of the problem is, from what I know, and I think it's not just a problem over here, there aren't enough PCRs to go around anymore. And so countries are starting to use antigen tests.
That's this sort of lateral flow.
Yeah, but I've got to be honest, I think that, and I'm not the only person who thinks this, I know quite a lot of my colleagues say this, we don't think that they're so accurate with Omicron. So if you've got the right symptoms and you've got a positive test, I'd suspect that the test is correct. But I've definitely seen quite a lot of people who've had very clear symptoms and they keep getting negative tests, and I send them for a PCR. And I want to say that usually the PCR does come back positive for the right patients. But I don't rely on these tests alone, and I have a very low threshold for thinking that this is actually COVID rather than some other virus.
Yes, I mean, I think that's really important, that every patient who's sick should receive a diagnosis. And of course, in medicine, there's always a differential diagnosis.
Yeah.
So just because it sounds like horse's hooves doesn't mean say it's not a zebra. It could be, as you said, it could be whooping cough. It could be something.
Yeah,
different.
I've definitely had quite a few patients who have a really hacking cough, where they leap off their bed, where they have headaches after a bout of coughing, sometimes backaches, chest aches, and actually when I had COVID before there were tests available, which was right at the beginning of 2020.
But you had the initial strain right at the start, didn't you?
Yeah, and I actually thought that this was whooping cough, though I'd already had whooping cough 3 years prior. And so I actually tested myself. Well, I got tested for whooping cough at the time, and it showed out to be negative. And that's, and then later on, obviously, I was able to send off an antibody test and found out that it was in fact COVID. But the symptoms were very, very similar. This kind of choking sensation in the middle of the night, waking me up. It's quite scary. And I've had a few patients with COVID with Omicron who also have a similar kind of experience. And I suspect it's partly just that they have a lot of thick mucus and they're lying down, and suddenly in the night when your airway is actually relaxed, so the muscles are kind of floppy, and the airway itself is not, it's not got a good degree of tone, because that's what happens at nighttime to our muscles. So in the middle of the night, they're sort of waking up, finding it hard to breathe, and that's a very scary experience.
And the cilia get going overnight, don't they, wafting all this mucus into the trachea?
Well, the cilia do get going, but I mean the main issue with I think why it's so
muscular
is exactly because they're asleep, and because the tonus of the muscles holding the airway up, holding the airway together, has actually dropped.
Right. Okay. Yeah. Interesting. Yeah. So we did mention lower respiratory tract infections. And so out of hundreds of patients who've been complaining of upper respiratory symptoms, you only had 5 that you suspected of lower tract infection.
I might be underestimating, maybe 10 or maybe more than that. I'm not sure. But for a lot of people, it's about trying to figure out, where are they? Do they have upper respiratory only? Is it developing into pneumonia? Is it not? And obviously trying to prevent them developing a worsening.
Sure. So if you were unsure about that at all, you'd send them for chest X-rays, presumably, too.
If I think that on balance it's going to be better to send them for a chest X-ray, then yes. There's obviously another problem with sending people for a chest X-ray, which is that you're exposing other people to them.
Sure.
You've got a person who's coughing quite a lot, and then you're going to send them for a chest X-ray in a department, whether it be a sort of emergency department or whatever, and you're potentially going to spread the virus even further. So you're not going to do this for everybody. You have to be careful. You
have to be selective, yeah. And you'll have a pretty good idea from listening to the chest and the patient's clinical features if they have got a pneumonia.
Yeah.
Are you getting any? Sorry, go ahead. Go ahead.
No, I'm going to say sometimes you don't know, and you have to think, well, what on balance should I be doing here? For many people, I'll end up giving them an inhaler, for example, kind of inhalers that we use in asthma. And for many people, that will suffice and that'll be enough. And they'll report to me if they're developing a fever, if things are worsening, whatever. And then I might think about whether they should have an antibiotic. Obviously, if they're a high-risk person, we would think about whether they need to go to the emergency department. The other thing with Omicron is that the monoclonal antibodies don't seem to work so well.
No. The monoclonal antibodies were designed for the previous, well, for the wild type variant, weren't they? The B11, right. And there's been a big shift in the
basically not being used here. I mean, they are using the drug from Pfizer, Paxlovid, but that's also a very selective process as to who gets it.
Yes. Are you seeing any lower tract infections associated with pain that might indicate pleuritic involvement?
I do see some, yeah, but I haven't actually picked up anyone with clear-cut pleurisy. So actually, when I listen to them, when I go into the story in more depth, it's rare. And in fact, most of them, I would say, are developing a pain in the chest, a musculoskeletal pain. So the actual ribs are hurting from some of these strong coughs. Yeah. Have I actually picked up anyone with clear pleurisy, which is when the lining of the lungs actually is sort of inflamed? And then every time they take a deep breath, they get pain. Not many people. Not many people.
So that would indicate that even alone the rare times that we get the lower tract infection, it's more of a bronchopneumonia rather than a lobar type.
It's definitely the large airways up here and going into the beginning of the lungs. That's what seems to be the case.
That's the main thing with Omicron. Yeah.
Right. I mean, that makes sense with the kind of pathology you're looking at.
So I'm reassured, really. I think you're saying you're not seeing too much in the way of secondary bacterial infection.
That's correct. I mean, having said that, as you know, we spoke about just earlier, there has been a very significant spike in cases over here. Not just, obviously, the infections, the number of infections per se doesn't matter so much, but it does matter how many people actually get admitted into hospital and how many patients actually end up on ICU.
Because the actual hospital admissions in Israel aren't that high. They haven't gone up that much. But what's interesting about Israel, and I know we don't know the answer to this question yet, but the proportion of patients going to intensive care is a fair bit higher than the UK. And I think in a few weeks' time, we might know the answer to that. I don't think we do at the moment, but it's...
You mean we might know the answer as to why it's happening?
Yeah, or have you got any ideas now why there's more admissions to intensive care?
I honestly don't know. I mean, there are some suggestions about this. The people maybe. The problem is that I don't know what proportion of them have been vaccinated and to what degree.
Actually, Israel's interesting again. Although, first of all, a lot of the vaccination program was carried out in the early days of vaccination. Israel was very advanced, although we believe that the memory T cell immunity is going to last for quite some time. It should be within the range of that. But there's actually quite a lot, even though Israel was extensively vaccinated in terms of doses.
Yes.
There's actually a fairly large percentage of the population weren't vaccinated at all.
Yeah, I mean, there's a significant proportion that wasn't vaccinated at all. Yeah.
So interesting things to come for sure. Now, bearing in mind, and everyone will be scrambling to see it after this, of course. But we did a video on vitamin D, didn't we, a few weeks ago? So now at this point, I have to say that Dr. Cohen nor myself can prescribe treatments for you. You have to go to your own doctor.
Absolutely.
But so that's our disclaimer. So we're talking purely in educational terms. But the question is, what general advice are you able to give to your patients to reduce their chances of getting severe illness should they become infected?
Well, I mean, I will go back to saying it because I've been banging on about it for the last 2 years. I think there is enough to suggest that vitamin D is extremely safe for most people. Yeah. Obviously, it should be discussed with your doctor. Yeah. But vitamin D given at the right doses to get good levels, not the kind of doses that are used to prevent or treat osteoporosis or rickets, but doses that will get a very decent level, which I won't go into right now.
Personally, I'm taking 5,000 units a day, but that's only for me personally. Essentially.
That may work.
It's not a recommendation, but it's just what I'm taking.
It's a recommendation. If it works for you, then that's fine. Yeah. People who are using doses above 4,000, though, probably should be using K2, vitamin K2, not vitamin K. Vitamin K2 is a big difference. between their effects, because it balances where the calcium goes in the body, and vitamin D can affect calcium levels. And the other things are zinc, a low dose of zinc, so probably around 20 milligrams is fine on a long-term basis, on a daily basis, of the elemental zinc. And the other thing is, if someone actually becomes sick, to use vitamin C at the time that they're sick. And yeah, those are the main things I would say.
And these are such basic things that anyone can do on their own at home, aren't they? They're just not.
Yeah.
We do know that people are short of vitamin C. People are short of vitamin D. For some reason, very often people don't get enough zinc and absorb enough, and vitamin K too, because it largely comes from fermented foods. In the British diet, at least, we basically hardly get any. So
there is supposed. I mean, if you're talking about K2 right now, K2 is supposed to be found in eggs. So if you have probably 2 or 3 eggs a day, that would be a reasonable amount of K2.
I think it depends what you feed the chickies on as well, though, doesn't it?
For sure.
If your chickens are just fed on like soya beans all the time just to maximize yields, so free and fortunately, I don't know what it's like in Israel, but in the UK now, free range eggs are
not
really quite affordable.
Right.
The price difference between free range and caged eggs is. I mean, personally, I just couldn't contemplate eating a caged bird egg. My conscience would just rebel against that.
Right.
Whereas the free range ones, I eat quite a lot. So, but I'm reassured to hear you say that. So I'm probably getting some vitamin K2 from.
You must be getting some. I don't know how much.
From my eggs, yeah. So patients with a new diagnosed viral infection, what sort of things do you tell them to look out for? What do you say? Look, we call this red flags in medicine, don't we?
Yeah.
What do you say? Well, look, ring me immediately if, or contact the hospital if. What sort of things are you worried about could happen to your patient self-caring at home?
Well, firstly, I'll say it with Omicron, I've seen obviously a lot less of these concerning types of symptoms, but people who have very high fevers that are not settling down, people who are feeling a difficulty in breathing, certainly if it's worsening, if they're getting choking sensations in the middle of the night and waking up and finding it hard to breathe, or at any time, but it often happens at that time. If people are losing their appetite, I often see, it seems to me, this is purely from my experience, but I use appetite a lot as a measure of how sick somebody is in general. And I think everyone knows this in medicine, and many lay people do, certainly when families were more nuclear in the past and there was a grandmother in the picture, she would have said, oh yeah, I've lost their appetite. It was a bit more serious. So someone who loses their appetite can be an important sign to look out for. Obviously, if anyone develops any strange features that you haven't seen or heard of, cracking headaches and things like this, you'd want to know about it. But yeah, those are probably the main features of someone, for whatever reason, if someone can't eat or drink, but that's going on to much more severe.
At least it merits a medical reassessment, doesn't it?
Yeah.
They can be checked out again. Because I know a lot of people have reported to me with Omicron that they actually feel pretty rough for a few days.
Yeah.
Mild. When I say mild, I mean, I used to work in intensive care units. If you're ill, you're really ill. But mild doesn't necessarily mean mild. It just means that you're less likely to develop acute sequelae or acute complications. It doesn't mean to say you're not having a really rough time.
For sure. And some of the patients who I've seen have had a really rough time, and they said they were not for six. They didn't know where it came from. They thought it was going to be a mild illness by comparison. From my comparison, I also used to work on ICU for a while, and I used to work in acute medicine, emergency departments, all sorts of different acute settings of medicine and surgery. And from my point of view, anyone who doesn't end up in hospital has had a relatively mild course of illness.
That's right. Yeah.
Even if they feel awful with it, the fact and that was the whole purpose of the strategies around how do we manage this pandemic. Everything was about preventing hospitalizations, and then on top of that, preventing ICU admissions. So it's about keeping the illness within the community.
We should really change that medical description from mild to mild, open brackets, but you could feel dog rough for quite a few days and don't worry about it, close brackets, sort of. It's just well, wait.
Absolutely.
Mild means it's not causing you and me a metaphorical headache in an A&E department or an intensive care.
Someone's going to get through the illness, even if it takes a long time, but they're not going to have to be admitted into hospital and or be at risk of significant acute consequences.
Sure. What sort of recovery times are you seeing? I mean, I know you basically when the patients feel better, they stop bothering you, which is so it's difficult to tell. But are patients bouncing back in 3 days, or is it, are we getting sort of any early indications that there might be some long COVID associated with Omicron?
So I'm seeing a lot of my patients tend to have it for a few days.
Yeah.
Some of them have it for a day or two. Some of them have it for 3 or 4 days. Some of them have it for 5, 6, 7 days. And that's been most of the experiences that I've noticed in my practice. I have also seen some people who have afterwards been very fatigued. I've seen people afterwards having breathing difficulties. I suspect that they've got something else going on a lot of the time, something like long COVID, which is too early to diagnose by definition, but they have the kind of things that are clearly not in the realms of the acute infection, and they're the post-acute infection. And definitely seen people with a kind of POTS-like syndrome, which is postural orthostatic tachycardia, and they clearly, they just walk a few steps and their heart's racing,
and they can feel that as a palpitation.
Right, but when you actually examine them, they sound, you listen to their chest, they sound okay, everything seems okay, but they've clearly got something going on there.
Does that set to settle down, or can that drag on for a while?
It can drag on for a long time. It can drag on for
weeks.
Months. It can drag on for months, and even there've been a lot of case reports of people going on past a year or longer. And we're starting to understand now what the mechanisms are behind that.
Very disconcerting, isn't it, when you get when anything wrong with your heart? It feels very unsettling kind of thing.
It's very unsettling. It also knocks someone's confidence. A lot of people in the past, certainly with the syndrome POTS, but also it comes under the whole realm of chronic fatigue syndrome, is that classically for many years the medical world looked at these as people who are just stressed or who were experiencing psychological effects, and that's got an element of truth in it. But then that would be the case with anyone going through certain symptoms like that, and then having to recover from that in a very slow way. So yes, I think the stress is definitely one of the contributing factors.
But it doesn't mean to say that there can't be a completely organic biological cause for the.
And I think many times there is an organic biological cause that is being being perpetuated by various factors. One of the factors may be the stress in itself. Another one may be the narrative that the person holds towards themselves. But we're probably going a little bit off topic here from what you wanted to talk about.
I'm always going off topic. Right, a lot of that's my concern. Just to summarize that section, that we really don't know, given that everyone's being infected with Omicron, or everyone's being exposed to Omicron, how prevalent is the long COVID sequelae of that going to be? Now, I know we don't know the answer to that question. It's a concern, given that Omicron is, in a sense, a less systemic disease than, say, Delta. I'm hopeful we're not going to get a lot of long COVIDs, but of course we simply don't know that.
No, we don't know that
until we collect the empirical data.
We don't know that, and like I said, I've seen a few people who've got these kinds of symptoms that are suggestive that they could go on to have longer COVID type illness. I do think that there's quite a lot of data emerging though now, also from previous variants, from Alpha, from Delta, that long COVID symptoms are amenable to being altered in how severe they are and how long they go on for. And my suspicion is, again, that there are aspects of basic physiology that we need to focus on. And I think that, again, there's very little harm, or almost no harm that I can think of. And these things should be prescribed by a doctor, obviously, and it should be followed up by a doctor. But some of these basic vitamins and supplements may be very helpful in both the prevention of and in the attenuation of such symptoms as come up with long COVID. And I think that they should be taken before a person becomes ill in the first place, and during the illness, of course, and well beyond.
Yes, it's prevention, treatment, and follow-up. All three are important.
I think, I mean, the strategy for those kinds of supplements needs to be one of, well, this is what this person's going to be taking more or less from now until they have COVID or not, and until the end of the pandemic.
And even if they don't have COVID, it's a generally healthy lifestyle anyway.
Some of those things are, but in a normal situation, you wouldn't necessarily be telling people to do this.
Yes, that's right. Yeah, we are in an emergency situation now where it might be more reasonable, for example, to take a zinc supplement for the next few weeks rather than necessarily taking it for the rest of your life.
Absolutely. And of course, the usual things come into play, trying to ensure that a person has good diet, sleeps enough. I think sunshine in itself, there is enough evidence to show that sunshine in itself. I mean, Florence Nightingale was treating people with TB in hospitals where they basically pushed beds out onto a balcony, and they saw that they were having better survival rates in the sunshine. Now, you've got UVA and UVB, right? UVB is what activates the production of vitamin D in the dermis, deep skin. But UVA has other effects, and it probably has effects on the mitochondria. And these are the kinds of things that we have sort of forgotten with modern medicine.
It's interesting, isn't it? Things that people have done and developed like almost empirically, because it seems to work, we're now finding physiological scientific rationales for. And I think the microbiome is another example of that. Just an infinite fascinating area of all these bugs that live inside us. It's just
I'm sorry for laughing. It's just the subject expands.
Oh yeah. Let's just suffice it to say that Tim Spector's advised me to eat 30 different plants a week.
Probably with a good evidence base for that.
Oh yeah.
The diversity of the microbiome is contingent upon the diversity of your diet.
Absolutely, yeah. Right. Last important point I had: sick children.
Yeah.
Are you seeing mothers bringing their children in worried in the Omicron wave?
Not so many. I'm in touch with people whose children have picked up the virus and who are in isolation at home. Most of these children are absolutely fine. A couple of them have had high fevers going on for a couple of days. Obviously, we know that some children can become quite sick, but I haven't seen many getting very unwell or being hospitalized.
This is pretty reassuring, isn't it? So we're not seeing what we were worried about was the effects on the circulatory system, the acute respiratory distress syndrome that we're worried about. So far, you're not seeing that. I mean, I know we can't say that doesn't happen, but it's not your experience over the past.
It's not been in my experience. Obviously, it's happening somewhere. It's not been in my experience.
Yeah, but you've got a pretty good slice of general experience, so that is somewhat reassuring.
I mean, it's something, but it's not. Obviously, you can't use it to base population strategy on.
No. Right. So, is this virus going to become endemic? Answer yes or no.
I think most likely yes.
Yeah, for the next few seasons at least. I think that's guaranteed for the next few years.
Yeah.
And do you think basically that because we've got these good levels of immunity, we're just going to live with it as we do with all these other irritating milieu of viruses and bacteria we live in already?
I mean, I'm not a prophet, so I don't know, and don't hold me to anything. I expect that this is just going to be one of a number of viruses. It's certainly a very interesting virus. It certainly seems to be able to do things that we haven't seen this kind of diversity of effects from other viruses, but it's also possible, when the Spanish flu happened, the perhaps wrongly named Spanish flu, when that occurred, there could have been all sorts of other things going on that we today would be unaware of. Today we have this ability to diagnose various things, whereas once upon a time people may have brushed off certain symptoms and just said, well, yeah, you got this and maybe it's to do with the flu, maybe it isn't. Here we're actually trying to dissect and find out, what is this symptom? What is that symptom? Why are so many people so tired or breathless afterwards? It was a different world 100 years ago where people would just, get up and get on with it.
But even then, it was recognised. There was encephalitis lethargicus.
Yeah.
There was and a subset of that was post-encephalitic Parkinsonism.
Yeah.
So these things were epidemiologically recognised, but there was probably, as you've said, 100 other things that weren't epidemiologically recognised.
Right, but encephalitis lethargica was it was something that was pretty severe and very very unique in its presentation. You had these people who were basically stuck in some physical position, locked in some way, and it was an unusual thing to see.
Almost like a zombie syndrome, wasn't it? They were aware but not taking an interest in their environment.
Right. Yeah. I mean, there was obviously probably a lot of people are aware of this. They've probably seen the film Awakenings, based on the true story of Oliver Sacks, the neurologist, who actually treated them with levodopa, which is still one of the fundamental drugs for Parkinsonism. And seeing these people wake up after years of being in a stuck physical position with apparently no interest.
Fascinating. So we need to spend another, I don't know, 30, 40 hours. I'll probably do it at some point to unpack all of these interesting bits that we've just glanced over. I'm just reminded of something. I was a psychiatric nurse when I was 18. So when I was 21, I did my student psychiatric nurse training, and we used to have a condition then called catatonic schizophrenia. And we only had a couple of patients, but they used to go into this position and they'd just stay there for hours. And now that condition just doesn't seem to exist.
Well, I think it's partly
it's weird.
Partly it's also the drug treatments have changed. Using some of the antipsychotic medication of the last 20, 30 years has been pretty effective. I mean, obviously it hasn't cured schizophrenia, but it has been pretty effective. Yeah, I mean, catatonic schizophrenia was pretty awful.
Yeah, quite frightening to see, really.
Catatonia in general is a pretty awful thing to experience. It's not always part of schizophrenia.
Yeah, indeed. Dr. Cohen, again, fascinating, your personal experience. We'd love to get an update. My prediction is that the wave in Israel will be as short-lived as the wave in South Africa, based on the fact that the UK wave is following the sort of narrowness.
Right. I mean, if you look at the
South
graph,
African wave.
If you look at the graph of this particular wave compared to the delta waves, the deltas were this kind of thing, like that, and this one is. Yeah. And one hopes it's this.
And there's some new data coming out showing that the natural infection does seem to be generating pretty good levels of immunity. I haven't studied that in detail yet, but we've suspected it for some time, but the evidence for that does seem to be coming out. So that gives me quite a lot of scope for optimism, really, that we're all going to have a pretty good level of immunity to SARS coronavirus too.
Yeah, I would hope so. I think with Omicron, you've got a lot of epitopes on the virus. You've got a lot of immune stimulation going on in various areas, and there is the potential for it to prevent other variants from taking hold.
Yes. So what we're saying is the body produces about 20 or 30 different types of antibodies to this one virus that will neutralize and do other nasty things to this virus and different things. I'm sorry, I'm just distracted then because I'm looking for a word. It turns it from being liquid into solid. It clumps it all together. It can agglutinate the virus.
Agglutinates.
Yeah, probably agglutinate is the word. Yeah. Anyway, it can neutralize many different parts of the virus. So if there were, say, a radical shift in the nature of the spike protein, then the antibodies that are being produced now in response to Omicron would still attack the membrane protein.
Yeah, well, I hope so. I'm certainly no virologist. Everything I've read seems to point to that. Hopefully not too many more surprises.
We indeed hope so. Yeah.
But again, I will add this one thing again, just to reinforce. We can't predict these things, you and I can't, I don't think, and even with all the best virologists, they've been able to predict certain things, but not everything. Yeah. And I still think it's important that we keep a focus on maintaining general health.
Yes.
If we keep trying to, it reminds me, if I have one more minute of your time.
Please, yeah, please.
It reminds me a little bit in medicine, if we go back to the time when penicillin was discovered. I think that was a turning point in medicine whereby we stopped thinking about the whole body as a unit, and we started to think, we can find actual specific cures for specific bacteria, therefore we're going to target certain lesions in the body, whether it's a bacterial insult, whether it's a virus, whether it's a cancer, whether it's an antibody, whether it's an autoantibody, whatever it be. We started thinking in this very microscopic and almost tunnel vision way, unfortunately, which has its benefits. It's important. We need to know what is the thing causing the illness, but what the downside of that is that we have, as a medical culture, I think, have forgotten that if we actually strengthen the entire body, then the body can also do a lot of that work. And it's the body that's doing most of it anyway. Even when we give someone an antibiotic, the antibiotic often doesn't kill the bacteria, but it may stop the replication enough so that the body's immune system has time to react and treat the infection itself. So again, it's very much about, yes, we've got to do all the clever things, but we need to think about a person as a whole human being and how to support a whole human being. And that's why these other things are so important.
Absolutely. And if you don't feel humbled by the complexity of the body that Dr. Cohen has just described, play that bit again, because it means you didn't quite get it, because we just live in this most amazing body, which is, as you rightly say, is a whole. Yeah, great. And I think we'll close on that point. I'm sure we could go on, but Dr. Cohen, once again, very grateful for your time. Some fascinating insights. I think a lot of people are going to feel quite reassured having watched that video, and you'll be pleased to learn we've kept that down to 44 minutes. So thank you very much for your time on this Sunday evening, and I know you're back at it first thing tomorrow morning, so we really do appreciate taking the time to talk to us. So thank you very much.
Take care.
Thank you.